Welcome. It is Ask Dr. Geier Live, wherever you're watching. I hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help you feel, look, and perform your best regardless of age or injuries. This is the first time I've done this now in 2 months because last month something came up at the absolute last minute and I couldn't get over here, and then just basically every Monday after that was booked up. So I apologize, but I am super excited to be back to answer any orthopedic injuries, surgeries, rehab, recovery questions that you might have. A few little housekeeping things as we get started. If you've been here a lot, you probably know most of these and you're sick of me explaining it, but let me do this anyway. I stay and answer all the questions that there are. That could be 30 minutes, that could be 5 minutes. It just depends on how many questions you have. I am not giving medical advice. I say this in all my videos. I say this on my live streams. I cannot give medical advice online to people who aren't my patients. This is meant for general information and educational purposes only, and so just take that for what it's worth. Having said that, this is usually very helpful for somebody that's either seen an orthopedic surgeon but doesn't understand what he or she said, or you have an injury, you're not sure if you should see an orthopedic surgeon, maybe you don't know what questions to ask, that kind of thing. I can hopefully help there. Also, if you're wondering how to ask a question, leave it in the chat, which at least on desktops and laptops is on the right side of the screen. Wherever this comment is, look for that, enter it over there. Good seeing you as always, but look for that. Do not leave it in the comments. I cannot see questions in the comments. And I say that only because every time when I get off the show, I do a little housekeeping in YouTube, and I see people leaving that they left comments or questions in the comments, and then wonder why I wasn't able to answer them. Well, I didn't see them. I can only see what's in the chat, what you're seeing on the screen right there. So look for the Show Life Youngs in the chat and leave those there. Last thing, if you're a military veteran and you have questions about disability claims, service connection, DBQs, nexus letters, that kind of thing, I don't do that in this show. That is in the show that starts at 5:30, Veteran Nexus Letter Live. Just go to YouTube. I think it's youtube.com/Veteran Nexus Letters, or just search Veteran Nexus Letters, Dr. David Geier, something like that. My channel will pop up, and then just join this live stream just like you're doing now. But like I say, happy to talk as much as possible about whatever the questions are. Just know I cannot give medical advice because I haven't seen you, haven't examined you, haven't looked at x-rays or MRIs, and it's illegal in the United States to do that in states you don't have a medical license. And so unless you're in North or South Carolina and you're a patient of mine, this is not medical advice. So, all right, let's do this. Very good to see you here on the live show. Very good. Not relevant, but in your opinion, what's the best major for someone looking in a career for orthopedic surgery? So I am going to disprove the common narrative that it would be biology or really any science. I was an economics major, so it really doesn't matter. Med schools don't really care about what major. In fact, a lot of them look very fondly on non-science majors. You're going to have to take biology, chemistry, and organic chemistry and physics regardless, sometimes statistics and calculus sometimes, to take the MCAT, and you have to have that for med school as part of the pre-med track. And if you like biology, by all means do it. If you like chemistry, by all means do it. As somebody that I'm long removed from academics, but the first 8 years of my career were in academics, and I actually sometimes would interview med school candidates or be involved in the reviewing resumes and applications. I think things that make you stand out are always good, which is why I'm not super big on the biology or chemistry unless you just like it. I think either something like an economics or philosophy or math would be very beneficial. Just it's something to talk about in the interview. I think some sort of engineering would be super helpful, biomedical engineering especially, but that's different and they tend to be very smart and good thinkers, so I think that bodes very highly. I think something like a kinesiology or something, not just sports medicine, but kinesiology, something like that would be very beneficial. There's no right way to do it, unfortunately. And to be fair, the major is only one part of many, many pieces that I'm happy to talk about some other time. But definitely lots of options out there. All right. I can't even say that. I don't know your name, or I'd say it by name. But anyway, I had a total rupture, no pain when it happened, no pain 3 weeks until surgery. Surgeons never met anyone with no pain. How rare is it? It's hard to know without knowing a rupture of what tendon, ligament that was. But yeah, that would probably be a little unusual. Patellar tendon, Achilles tendon, quad tendon. Trying to think. Rotator cuff, maybe not so much, but Bill, still a fairly unusual thing. But let me know what the body part is. I may be able to put more perspective on it. Dr. Geier, looking for a consult, second thought, shoulder replacement, work with the VA and have my own private insurance. So like I said at the beginning of this, if it's a disability claim thing, that's in my next show at 5:30. But having said that, for people with arthritis, potentially shoulder replacements, that's largely what I do in my medical practice, which is separate from the veteran work I do. But in my medical practice, very often try to help people with arthritis avoid joint replacements. Typically it's knee and shoulder, or knee and hip more than shoulder, because that's just way more common due to weight bearing of the hip and the knee. But there are regenerative treatments that can help slow that process and hopefully prevent that process. Almost none of them, and this is not just true with me, this is true across the United States, that those type of treatments are not covered by insurance, and so you pay out of pocket. So private insurance, whatever the health insurance is, TRICARE, any of that, none of it covers any of that. So like most regenerative practices, anti-aging, longevity practices, we don't take insurance. But there are a number of things out there to slow the disease process, but also try to rebuild damaged bone and cartilage that can be effective for a lot of people. So again, I do it separate from my VA work. There's on my contact form on my website, there's a link to schedule an appointment that'll get to me or one of my assistants, and we can kind of talk somebody through that process. This show is not really to promote my practice, but I am happy to potentially see people, and depending on sort of the other factors, we can sometimes do a Zoom consult before you travel to Charleston, South Carolina to see me. So certainly happy to do that. He says kinesiology. Yeah, I will say I don't know kinesiology well, but when I was in academics, one of our researchers was a faculty at a nearby college as well, and he was a kinesiology professor. Apparently it was hard as hell. But I think you learn a lot in kinesiology, and certainly good for orthopedics. I don't know orthopedics specifically how much biology, chemistry, physics matter. Physics maybe a little bit, but even that, I mean, you're putting things back together. You just need to get into medical school, then in medical school get really good grades, because orthopedics tends to be top 10% of the medical school class, despite the broke bone me fix kind of attitude the rest of medicine has towards orthopedics. But that's because they couldn't get into orthopedic surgery, and they're jealous. But and I say that somewhat with a grain of salt, but the top 10%, that's where the orthopedic surgeons come from. That part's true. Okay, so she says total patellar tendon rupture. That is very unusual that wouldn't hurt. You think somebody with a diseased patella tendon, maybe from fluoroquinolone antibiotics or something like that, that's really unusual. No pain until 3 weeks before surgery. Yeah, that's very rare. I don't, other than a not congenitally, but diseased tendon for some reason that just sort of gradually gave way. That's really unusual. Usually it's a very traumatic event. You land awkwardly from a jump. Like athletes start from wide receivers start from a fixed position and then suddenly take off. You can do it that way. It's typically more landing on your knee in a certain position, and it's sort of an eccentric load that pulls the patella tendon off the patella, and yeah, you know it right away. It feels like a gunshot, so to speak. Ariana, what question to ask my orthopedic surgeon when I go and talk about my knee? I don't know that there's any particular questions whenever you go to the doctor. I think it's more related to making sure you explain sort of the mechanism of how it started, whether it's acute or something that developed over time, being very specific about what the symptoms are, where it hurts, what other symptoms, swelling, giving way, locking, things like that, what treatments you've had up to that point, whether it's anti-inflammatory medications or prescription medications or heat or ice or physical therapy, home exercises, massage, acupuncture, any of that kind of stuff. If you've had any injections, things like that. If you've had x-rays or MRIs, and if not, they'll probably do at least x-rays in the office. Those are sort of the main things, getting sort of all the information there. If you've seen prior doctors or orthopedic surgeons, having those records can be helpful so that you can articulate what's happened in the past, especially if there's like a history of surgeries before. It amazes me how often, not so much in my practice now, because people in the anti-aging, regenerative medicine, longevity, they know their medical histories backwards and forwards. They're very proactive. But in my first 16 years of my career, both in academics and in private hospital, you'd be stunned how many people have had surgery and have no idea what that surgery was, like what was performed, when it was done. I mean, it's way more common that people don't know that than they do. And a lot of times that's really helpful when you're seeing somebody that might need another surgery. So that kind of thing, I think, is where it's really important. If you have prior x-rays or MRIs, bringing those studies, or at least the reports of those studies, can be helpful. I think all of those are pretty much the right way to do it. The way medicine is now, they try to rush you through appointments, and that's unfortunate. But I mean, you are there to get information about what's going on. So I think presenting all that information is good, even if it takes 10, 15 minutes to do that. I think that becomes really important. Do I still operate and do joint replacements? I do not operate anymore. So I never did joint replacements outside of my training. I did sports medicine, so that's mostly arthroscopic surgery. There are some sports medicine surgeons that also do knee replacements, but for the most part, sports medicine is more arthroscopic. So arthroscopic knee, shoulder, ankle, sometimes elbow, sometimes hip, that kind of thing. Whereas the joint replacement surgeries are done by joint replacement surgeons, fellowship trained joint replacement specialists, whereas ACLs, rotator cuffs, labral repairs, that type of thing is typically your fellowship trained orthopedic sports medicine. When I switched to regenerative, I stopped operating. One, because it's cash based, and yes, I probably could have done cash only surgery, but that's a lot to ask. People just don't want to pay $25,000, $30,000 out of pocket, even if you made a discount. That's just a lot to expect when you can go use insurance somewhere else. But in something like New York and LA, there are cash-based orthopedic surgeons at Hospital for Special Surgery. I know there's some. I know with Curl and Job out in LA, there's some, so it can certainly do that. I wasn't really interested in that. I'm trying to help people avoid surgery, so to also do surgery on the side was not something I was looking for. And then he says, I know a guy that happened to a guy in high school. Yeah, so patella tendon injuries typically are young people's, and I'm not being critical, but young people's injuries, typically under 30, and then over 30 or especially over 40, you get quad tendon injuries. But yeah, it is a non-contact injury. So when you think non-contact knee injuries, everybody thinks of ACL first, and that makes sense. It's the most common, but patella tendon injuries are typically non-contact, meaning there's not a direct blow to the knee. You're not getting tackled, something like that. Or if you are, that's sort of indirect, and it's an eccentric force on the knee that typically causes it. I think that's Aaron. Sorry, it's really small on my screen, but you guys can read it. I apologize. It looks like Aaron Harvey, though. I had an MRI, said oblique tear of the posterior horn extending to the tibial surface. Is that fancy talk for a root tear? It might be, but it might not be. And that's where, when you go to an orthopedic surgeon, yes, they look at the radiology results, but they're also going to look at the study. You can have a posterior horn tear that doesn't go into the root where the meniscus attaches. So that would be typically oblique, means it's oblique. It's going at an angle. It's not directly into the substance of the meniscus, which would be a radial tear. It's not a longitudinal or vertical tear. It's sort of a hybrid of those two. Typically, oblique tears are not the type that can be repaired. You typically trim out the inner part of the tear. But could it be extending to the root? Maybe. Most radiologists now are pretty attuned to looking for that, so I doubt it's a root tear, but I wouldn't say that it couldn't be. You'd really want to look at the images. The treatment is very different depending on what it is. Any experience or knowledge of a peptide called Vilon? I don't know how you say that. I'm not, but there probably is a different name for it, not just a trade name that I might be familiar with. But there are thousands of peptides out there, and more coming to market, at least through compounding pharmacies, and probably even more than that, sort of going through the illegal routes where they're just going direct to consumer, which is not allowed in this country, but people do it anyway, and that's a whole other rant I've done many times, and you can see it on my YouTube channel in a ton of the videos about peptides. But that may be a new one that I just don't know, or I don't know that particular name. Open reduction internal fixation on your arm, $14,000. Yeah, and that's probably, and I don't know, it depends on how long ago that was, but I mean, surgeries like joint replacements are $30,000, $35,000, but that's not all going to the patient. The insurance is picking up a huge part of that, and then the patient gets several thousand as a copay. But the whole system is, I'm not going to get into it here, but it's not right for sure, and that's part of it. Surgeon said patella tendon was healthy. How many patella tendon ruptures have you encountered? I've done several hundred. No pain. Yeah, I'm with you on the really surprised that there's no pain, especially because it's usually a very traumatic event. The patella tendon is not a little tiny nothing ligament. Just feel it under your kneecap. It's big, wide, it's thick. It takes a lot of force to rupture the patella tendon. So I can't say I've ever seen that. But I will tell you, I have not seen that, as somebody alluded to or in the earlier. I cannot say that I have seen that in people over the age of 30 more than a handful of times. It's typically not so much teenagers and college athletes, even though it can be. It's typically sort of weekend warriors, rec league soccer player type people in their mid to late 20s is where I typically see it, or somebody that falls down the stairs or does something weird. But even then, I've never seen it not pain. And the other thing that you typically see is if you have a complete rupture of the patella tendon, you can't lift your leg off the floor. Like, it's physically impossible, because now there's nothing connecting the quads to the quad tendon to the patella to the tibia. So if you can see that, so quads, quad tendon, patella tendon. If this is no longer attached to the tibia, there is no way to straighten your leg, to lift it off the ground, perform what we call a straight leg raise. So very quickly something is not right. The diagnosis is super easy, because you can feel the defect in the patella tendon. They can't lift their leg. You don't need an MRI to figure that one out. I can't say that I've seen one pain-free. All right. Ariana, patellar tendonitis has been causing me a lot of pain each and every day. It happened when I was lifting. So that's sort of a different animal, same body part, just now an overuse issue compared to a traumatic event. Patellar tendonitis typically starts out as an irritation of that tendon, but what happens, and it's usually at the inferior pole of the patella, sort of right there where the patella tendon attaches to the lower part of the patella. It starts out as a tendonitis, but very quickly it progresses to a tendinopathy or a tendinosis, sort of an internal degeneration within the tendon. That becomes a much harder problem to get to heal. You've got to somehow get that tissue to heal, get blood flow into the area. There's a number of ways to do it. None of them are typically easy. Cortisone you can't do, because that increases the risk of a patellar tendon rupture. You can't do that. Anti-inflammatories probably don't help that. They may help the pain, but they don't help it heal. You think of things like shockwave, you think of things like, maybe peptides, you think of regenerative injections directly into the tendon to try to get normal tendon to heal. Depending on the size of that tendinosis, and that's really not something you would know without an MRI or maybe an ultrasound, it can be a big enough section of the tendon, though, that you can try all that, but even that doesn't work, and then you're talking about potentially a surgery, which I've had to do a few times as well. But you try to prevent it from getting to that point. Have you ever seen a bucket handle meniscus tear? So I have done many hundreds of those. That typically is a meniscus tear that can be repaired as opposed to trimmed out. So I don't know how well this is going to show. But what it is, this is one of those orthopedic terms that is very literal. So it's a tear. I try to do this and keep it, but basically it goes all the way around the anterior and posterior horn, and the inner part can flip back and forth like the handle of a bucket. And what can happen is it flips into the center of the knee and then blocks motion. So it'll usually be a teenager comes in with the knee bent about 30 degrees. It can't straighten out. It can't bend. It is literally stuck in position because that meniscus is flipped into the center of the knee. So you have to go to surgery and put it back in place and then sew it back together with stitches or with anchors. It's great. Now, it doesn't always present as a locked knee, but you can still find that fairly frequently with ACL injuries or sometimes isolated meniscus tears. But it is the type, typically it's younger people, 14 to 30, and it's the type that you want to repair. You do not want to trim that out because it's most of the meniscus involved, but can have a good outcome and if done well. And she says, PT is the only thing that's helped so far. Yeah, that is not all that surprising. I'm a huge fan of physical therapy for sure. And he says, can I come to you and fix all my problems? I am certainly happy to help. You can certainly reach out to me. Information's in the description below, or the link to where you can get more information's in the description below this video. Okay, I have to run. These are all fantastic questions. I will be back here Monday, April 6th at 5 p.m. Very excited to do this again, and make sure this week to check out this month, check out all the videos. I'm in the middle of a series on a variety of different regenerative treatments for a variety of different orthopedic conditions, so definitely check those out. But I will be excited for you to any comments you have, any questions. I try to answer those on future videos, and as always, once a month doing these. I very much appreciate you all being here. If I didn't get to your questions, join me next month, and I will see you very, very soon. Take care.